Hi and welcome to GreenGP. Today I'm going to be talking about the red eye and the approach to the red eye in general practice. So the outline of my talk today, I'll just go through some of the more common presentations of red eye in general practice, my approach to the patient, some of the red flags to consider in presentation of the red eye, common conditions and their management, and some take-home messages. So some of the presentations I'm sure many of you have already seen in general practice are obviously the red eye, which we're talking about today, which can be both unilateral or bilateral, watering eye, otherwise known as epiphoria, or a discharging eye, swollen eyelids or blepharitis, a foreign body sensation, sensitivity to light, and reduced visual acuity. So when you're approaching the patient with the red eye, obviously we start with our history taking, so it's important to know when the red eye started, so how long it's been going on for, whether it started in one eye or if it's only in one eye or in both eyes. If the vision is affected, which is a really important one, I've just highlighted a few of those things in bold. If there's a foreign body sensation or any irritation in the eye or pain, sensitivity to light, they're all really important features which can point to more serious causes of the red eye, like iritis or bacterial keratitis or acute angle closure glaucoma. A history of itching or hay fever might point to allergic conjunctivitis. A history of trauma or working with metal could be the foreign body in the eye. It's important to know if the person wears contact lenses, so they might be at a higher risk of bacterial keratitis. Does the discharge, if they have one, continue throughout the day, which might be more likely to occur in bacterial conjunctivitis, if they've been in contact with anybody with known conjunctivitis, or if they've had a recent upper respiratory tract infection themselves. On examination, the person with the red eye, obviously we start with our general inspection, so having a look at the actual distribution of the redness in the eye, if it's around just the limbic area, which is probably more of a serious indication that there's something worse than just conjunctivitis going on. If there's any obvious discharge or crusting around the eye lid margins, check the person's visual acuity, and if they wear glasses, check it with their glasses on or with a pin prick, so looking through the pin prick. Check pupillary reaction with a pen torch. And the topical anaesthetic test is a really helpful test if someone's having a foreign body sensation in the eye or irritation in the eye, and you use the topical anaesthetic drops and the pain is relieved. It's quite reassuring that there's something superficial going on, usually in the cornea. If the pain is not relieved with topical anaesthetic drops, however, it could indicate something more serious like scleritis, an orbital process, so perhaps with the trauma history or foreign body, iritis, or angle closure glaucoma. And it's also really important to stay in the eye with fluorescein and have a look for any ulceration on the eye or the cornea. Very important to avert the lids, so you'll have been taught those methods hopefully through med school using a cotton bud. Check the patient's lymph nodes, especially if there is a history of upper respiratory tract infection and you're suspecting viral conjunctivitis. And important to note that diagnosis of conjunctivitis can only be made if there is red eye with discharge and normal vision and there's no evidence of keratitis, iritis or angle closure glaucoma. Cultures are usually not necessary unless it's a hyperacute presentation or is severe and you're suspecting something like gonorrhea. So I've already mentioned a few of these red flags. So reduction in visual acuity is a really important one. A ciliary flush, so I've mentioned this one, a pattern of injection where there's redness most pronounced in a ring at the limbus, which is where the cornea meets the sclera. Sensitivity to light, foreign body sensation. Obviously, if the pupil's not reacting, that's quite a scary thing. You'd be wanting to refer fairly quickly. Severe headache with nausea, another indication possibly glaucoma. Severe ocular pain, again, could represent glaucoma. Hypopyon, and just the usual caveat with this, just beware the unilateral red eye, and that comes from the Royal Victorian Eye and Ear Hospital's 35 Golden Eye Rules document. So just going through a few of the more common causes of red eye in general practice. So viral conjunctivitis is the most common infectious cause of red eye. So usually by adenovirus, and there's many types of adenovirus. It may be the only manifestation of the disease. There might not be any prodromal viral symptoms. It's highly contagious. It can last for 2 to 3 weeks. It usually starts in one eye, but the second eye is usually involved within the next 1 to 2 days. And patients might actually say, oh, but I've woken up with pus in my eye. What they're probably actually referring to is more the mucoid discharge, and there can certainly be eyes that are stuck together in the mornings with viral conjunctivitis as well as bacterial and allergic. And there might be follicles on the tarsal conjunctiva. So management is just symptomatic with this and being very careful with hand hygiene. Allergic conjunctivitis can appear quite similar to viral. It's usually, however, bilateral, watery discharge, and there's itching, which is a sort of a different feature. Again, there might be morning crusting at the eyelids, and there's often a history of allergy. So again, management with this is usually just lubricating eye drops and cold compresses. Topical antihistamines are more effective than oral antihistamines in this case. Sorry about the gross picture. Bacterial conjunctivitis, so the more common bugs are listed at the top there. It also is highly contagious. And interestingly, the redness and discharge is usually in one eye, but can also be bilateral after 1 to 2 days. And it usually develops fairly quickly with a discharge lasting throughout the day, so that if you wipe the discharge away, it appears again within minutes of wiping the lids. So management is usually with something like Chlorseq, drops and or ointment at least 4 times a day for 5 to 7 days, and it's important to keep reviewing the person, particularly the first couple of days. If they're not responding, you might need to refer. So similar to viral and allergic conjunctivitis, the affected eye is often stuck shut in the morning, so this is not a helpful differentiating feature of the 3 more common types of conjunctivitis. So in counselling your patients regarding conjunctivitis, remind them that it's highly contagious, so not to share towels and linen. If we're being really technical about things, the safest approach is just to stay home until there's no discharge. However, that's usually not practical with workers and people at university and high school. So generally the literature was saying just approach it in a similar way to how you would if the person had an upper respiratory tract infection. So staying home when they're at their worst, and returning, just being really careful with hand hygiene when they're feeling a little bit better. It's a good idea to let them know that the eye irritation might worsen for a few days or 5 days even before it starts to improve, and particularly in viral conjunctivitis, the symptoms can persist for up to 3 weeks, which patients aren't really very excited to hear. Also good to mention that the topical treatment agents themselves can cause irritation and redness, so it's a good idea not to use them for that whole time. So if they're getting symptoms for 3 weeks and they're using the treatments for 3 weeks, that really could increase their risk of getting a reaction to the treatments. And importantly, in general practice, there's no role for prescription of topical steroids or anaesthetic drops. And just a quick note on the difference between a stye and a chalazion. So the other name of a stye is a hordeolum, which really refers to an infection, and there's an external or an internal hordeolum. So the usual stye is an external hordeolum, which is an infection of the small sebaceous glands at the base of our eyelashes, whereas a chalazion is basically a blockage of the meibomian gland, leading to a cyst and granulomatous inflammation within the tarsal plate deep to the lash follicles. So usually it presents as a firm, non-tender, slowly growing lump, which may resolve over weeks or months. Some require incision and drainage if that doesn't occur, and they can sometimes become infected, which is then referred to as an internal hordeolum. So the treatment of both of these things is warm compresses applied for 5 to 10 minutes up to 4 times a day, followed by light massage, and you can use topical antibiotics if there is a mild infection going on. Take-home messages. Red eye is a really common presentation in general practice, so it's important to be aware of the more common causes and the red flags of what not to miss. So again, conjunctivitis is a clinical diagnosis of exclusion as long as there are no worrying features of keratitis, iritis or glaucoma. Topical antibiotic treatment may reduce morbidity and duration of disease in bacterial conjunctivitis, but obviously not in viral or allergic conjunctivitis. GPs should never use topical steroids and should never prescribe topical anaesthetic drops because they can be quite dangerous, and obviously if someone takes home the anaesthetic drops and continues using them because their eye is irritated, they're not going to feel further irritation and won't be able to protect their eye properly with that blinking reflex. And finally, beware the unilateral red eye. Just be really careful if someone presents just with one red eye, and make sure that you follow them up closely. So I hope you find this talk helpful, and hopefully it's pointed out a few things that you might be able to change in your practice. Thanks for listening.